Welcome to this discussion as part of the chemotherapy courses at Gustave Roussy. I am Benjamin Bess, a medical oncologist at Gustave Roussy, and I am pleased to be joined by Antonine Levy, a radiation oncologist at Gustave Roussy. We have chosen today's current topic to be stage 3 in bronchial cancer, particularly in bronchial cancers, because we will see that there are new developments for both non-small cell and small cell. So let's start. Antonine.
For non-small cell lung cancers and the role of radiotherapy.
Indeed, radiotherapy techniques have recently experienced technological advancements that reduce side effects, summarized on this slide, as it is now used for delineation, the PET scan, a reduction of irradiated volumes. There are also new techniques of modulation, intensity modulation and breath control that allow more healthy tissues to be spared, thus achieving better outcomes in treatment tolerance.
I remembered that the smaller your volume was, the greater your chances of being efficient. Is that true?
That's probably true. The reduction of volumes helps to avoid side effects. However, it is of course proven that concomitant and early irradiation performs better than sequential irradiation.
So, if I give you 2 or 3 cycles of chemotherapy before your radiotherapy and reduce the volume, does that work for you?
Well, yes. Most of the time, radiation on the primary tumor concerns the post-chemotherapy volume, but as proven by this PET plant trial, nodal irradiation is based on the initial PET scan. We stop irradiating the high-risk nodal areas, and again, reducing the volumes allows for better treatment tolerance.
Any follow-up after the chemoradiotherapy?
Yes, we are going to look at immunotherapy, and just before I was highlighting 2 trials were published this year in Lancet Oncology, which evaluates selective dose escalation. The first one, as you can see on the first part of the slide over, stereotactic radiation of the primary at a higher dose is the second part of the slide. The French trial RTEP7, which focuses on a dose escalation based on a PET scan performed during radiochemotherapy. These 2 trials give positive and encouraging preliminary signals and must, of course, be confirmed in randomized phase 3 trials.
So today, how much gray are you delivering?
Currently, the standard is delivered as 66 gray on the tumor and the invaded ganglionic areas, but perhaps tomorrow, a selective dose escalation on high-risk areas based on these trials. So indeed, following, as you know, radiochemotherapy, consolidation immunotherapy has become a standard with the Pacific trial. Durvalumab for 2 years in patients, non-progressors after radiochemotherapy. It should perhaps be highlighted in this trial. Here are the 5-year PFS results. We know that only 1/3 of patients are alive without progression at 5 years, which probably leaves some room for new advancements, new trials that we will quickly describe. Furthermore, question about whether stage 3 resectable neuron is curable. Yes, since in the Pacific trial, as you can see, 20% of patients did not need consolidation immunotherapy to be cured of their disease.
So, if I may, it is 1 year of consolidation in the Pacific with durvalumab. Should it be started before radiotherapy with my induction chemotherapy or immediately with the concomitant chemoradiotherapy?
Well, the Pacific 2 trial was just presented at the European Lung Cancer Congress this year. It's a trial that evaluates immunotherapy given from the start with concurrent chemoradiotherapy, durvalumab concurrently then in consolidation versus a group without durvalumab. So it's up for discussion since it involved countries where durvalumab had not been approved. So countries that might be a bit different from the countries typically represented in recent trials. It's a trial that unfortunately is negative, as you can see on this slide, in progression-free survival and overall survival. It was press release at the European Lung Cancer Conference this year. No difference between the 2 groups. Maybe if we look a little in the subgroups, we can see that durvalumab was stopped relatively frequently early on due to possible toxicities of the radiotherapy. Radiotherapy technique was not communicated in this trial, and once again in countries usually poorly represented in most immunotherapy trials.
And does that mean that Simultaneously, there are more toxins than expected.
So in this essay, the toxicity data were not described. However, the early discontinuation rate of durvalumab in the first few months of consolidation suggests that the irradiation volumes and radiotherapy techniques might not have been those usually performed in the most modern centers. Does Benjamin now have data in certain specific subgroups of patients? Are there hopes for personalization in stage 3?
So the molecular profile, it's been 20 years. Last year, we celebrated 20 years since the discovery of the EGFR mutation as predictive of the effectiveness of GFR inhibitors. Osimertinib, the third generation of inhibitors, has been the leader for a few years in metastatic first-line and post-operative settings. We'll see it again later. For patients whose tumor is EGFR mute, there was a missing category, which was stage 3. The LAURA study was presented this year at ASCO with data on recurrence-free survival of patients who had been treated with definitive chemoradiotherapy without durvalumab, of course, in the control arm, because the effectiveness of durvalumab is highly controversial, and it makes sense to have a control arm without durvalumab and on recurrence-free survival, an extremely strong hazard ratio. The study is clearly positive. And that makes osimertinib a new standard. We can still regret the absence of an obligatory PET scan before radiochemotherapy, suggesting that some of these patients perhaps had a metastatic disease. We are still surprised by the control arms curve, which is extremely bad. I remind you that the EGFR mutation is not a factor of poor prognosis, meaning that a patient with an EGFR mutation does not have a more aggressive cancer than a patient with a KRAS mutation, for example, regarding the natural progression of the disease. So this means that this control arm probably had either a less well-selected group of patients with the PET scan, etc., than usual, or radiotherapy techniques, radiochemotherapy modalities that are not optimal. And nevertheless, it sets a new standard, also hampered by the design of this trial, because as you said, stage 3 can be cured with radiotherapy. And in this trial, the regulatory authorities, especially the Food and Drug Administration in the United States and the European Medicines Agency in Europe, agreed that in the treatment, after a curative treatment, a lifelong treatment is given. So osimertinib in this trial is never stopped, which is nonsense. Post-operatively, it is given for 3 years, maybe more. So this type of scheme that we will have to move. And then there's a big question about the place of circulating tumor DNA. You know, these small fragments of DNA that can be captured with our new tests. Will circulating tumor DNA allow us to guide treatment? Maybe. What we know is that before operating, irradiating a patient, if we do not capture any circulating tumor DNA, it indicates a disease with a better prognosis. And if after radical treatment, surgery and radiotherapy, if no circulating tumor DNA is found, the prognosis will be much better. If we find some, we may be dealing with metastatic disease, and so there's a big debate about whether I should de-escalate or escalate treatment based on circulating tumor DNA. Today, these are tests available on the market in the United States that should not be used to guide treatment. Patients must be included in randomized trials.
Is a molecular selection of patients based on circulating tumor DNA, personalization on circulating tumor DNA possible in the future?
It is entirely possible that depending on the amount of circulating tumor DNA and the type of mutation found, treatment could be adapted. Nevertheless, the data we have with, for example, osimertinib in the preoperative setting, about 2 months of osimertinib. It's a study on about 30 patients that was published this year. Last year, sorry. We see that there is no complete pathological response with 2 months of osimertinib, whereas 2 months of chemoimmunotherapy or even 2 months of immunotherapy alone induce complete pathological responses. So there is still, let's say, a lack of data on whether targeted therapies can truly induce a complete pathological response and thus alter the natural history of the disease.
So we are indeed talking about the perioperative period. So what about consolidation, then preoperative immunotherapy?
So, perioperatively, we first have 3 adjuvant trials. I'm putting them back because the atezolizumab trial, which is the top one, allow for marketing authorization in the United States for patients whose tumors express PD-L1 at more than 1%, and in Europe more than 50% without reimbursement in France. The ORTC and ATOP study, the second one, PEARLS, showed there was a benefit to giving 1 year pembrolizumab compared to a placebo. The survival benefit exists regardless of PD-L1 expression, approved in the United States, not available in France. And then the trial we saw this year, last year at ASCO, is the trial with durvalumab, which is also negative, even in the subgroup of patients, where the tumor expresses PD-L1 very strongly. It is not extremely encouraging in the adjuvant setting, and it's certain that when we give immunotherapy, we think, since I'm stimulating the immune system, maybe it is preferable for the tumor to be in place when I stimulate my immune system to recognize a tumor. So the preoperative setting makes real sense. We have several studies now, I will mention 4 here. First, to tell you that they are very consistent in terms of hazard ratio. Regarding disease-free survival, we are always around 0.6. A Chinese study, a slightly better hazard ratio, but overall 0.6, which is very powerful. And today we have access to 1, a modality which is the following: 3 cycles of chemotherapy plus preoperative nivolumab. We have early access provided that the tumor expresses PDL 1% or more. And then the next one is the Keynote study, which also has a benefit in recurrence-free survival of 0.6, and which has a benefit in overall survival. It's the only one. Now, it's not necessarily because it's the best drug or the best regimen. It might be because we don't have enough hindsight regarding the other studies. Nonetheless, there is a European marketing authorization. There is no coverage in France for this regimen.
In your opinion, will there be a need for pre- and post-operative immunotherapy tomorrow, or will preoperative treatment be sufficient?
This is the big question. Do we need to do 1 year of post-operative immunotherapy? It is extremely costly. Obviously, it involves trips back and forth for the patient. It might mean more side effects. Today, we do not know. The next one, we have, a study that, a presentation, at the World last year, which may seem interesting, because with nivolumab, 2 trials were conducted. The CheckMate 816 trial, which is 3 cycles of preoperative nivolumab chemo, and that's all. And then the 77T, which is 4 cycles before surgery and 1 year after surgery. In this presentation, we compare the 2 trials. You know, these are 2 phase 3 trials compared to Chemosol without nivolumab. And here, we take the 2 curves of the 2 experimental arms that we show. Normally, we should not do this at the statistical level. We may see an interest, except that we compare 2 different populations. In the perioperative trial, we only included patients who received post-operative treatment, that is, those who had a general condition, surgery, received the preoperative, no post-operative complications, and thus eligible for post-operative treatment. These are patients who had not progressed either, whereas in the arm, neoadjuvant, the 816, we take all the patients. So we have a better group, which is the perioperative, but we selected the best perioperative patients that we compare with the rest. So the study with this hazard ratio is unfortunately something that is entirely uninterpretable and should in no way making perioperative care. The standard requires trials, and we will likely need to stratify these trials based on whether there is a complete pathological response, which is a factor of excellent prognosis.
We got the results in melanoma, which directly compared pre versus post. Are there trials starting to emerge or ongoing in lung cancer?
I don't need pre versus post. The preoperative data is much better. And the role of adjuvant chemotherapy, of adjuvant immunotherapy, ultimately becomes very limited. In fact, if we had access, we would probably offer it. At stages 2 or 3 of meeting, that is, we have a stage 1 patient, they are operated on immediately, and then ultimately it is a pathological stage 2, eligible for post-operative immunotherapy, theoretically later for PD-L1 over 50%.
So yes, now what about patients with molecular alteration?
And we will mention 2 molecular alterations. We mentioned it earlier. EGFR, 10% of our patients. These are patients who have undergone cancer surgery. Again, no information on the preoperative PET scan. These patients have chemotherapy, at least 1 cycle. This is important because osimertinib does not replace chemotherapy, it complements it. And we give 3 years of osimertinib or a placebo. This is the ADORA trial. And we are positive in progression-free survival. So obviously, we want to say that if we treat, it is not to delay recurrence, it is to cure better. And so it is the overall survival data that will really be interesting because, of course, there is, in terms of recurrence-free survival, an extremely powerful hazard ratio. But all these patients are operated on and know they have a tumor mutated in the GFR. So upon recurrence, we expect 100% of the patients to receive a GFR inhibitor. And the standard until now is osimertinib. We hope that all these patients will receive osimertinib so that we know if ultimately, for these patients, giving osimertinib at the time of recurrence is not sufficient. And then the last point is about ALK patients. It's the second most common alteration, if I exclude CRAS, of course. ALK is 3 to 4% of our patients who have cancer with an ALK rearrangement or ALK positive immunohistochemistry in our routine. And here, this trial is not like ADORA, since it compares chemotherapy to alectinib. So it is not complementary, it is in place of that. And we have very convincing curves on survival without recurrence. Here too, we are waiting for overall survival data. The debate is whether we should still conduct post-operative chemotherapy, especially with the doublet Pemetrexed platinum, because we know that ILK are particularly sensitive to Pemetrexed. That concludes the news on non-small cell lung cancers. Stage 3, let's move on to small cell. So first, before discussing systemic treatments, what is the best radiation therapy modality for small cell lung cancer?
For many years, the bifractional concurrent chemoradiotherapy, 1 session in the morning, 1 session in the evening, was the standard based on an old study by Roussy. The CONVERGE trial recently evaluated the scheme, 1 fraction per day in the bifractionated scheme. It's a trial aiming to show the superiority of the monofractionated approach. And as you can see on these curves, there's no difference between the two. Group with a slight non-significant advantage for the bifractionated treatment. Following this trial, bifractionated treatment still remains the standard, even though we know it is difficult to implement in clinical practice. Recently, 2 articles, one from the Nordic countries and the other Asian, have evaluated a dose escalation in bifractionated treatment for these patients. I am showing you here, therefore, the Asian phase 3 that compared the standard 45 gray 30 fractions to an integrated boost dose escalation, still 30 fractions, no longer, but stronger, more dosed on the primary tumor. And you see here a benefit regarding the bifractionated dose escalation. In these patients, the trial was stopped following these benefits and could be considered a future standard if confirmed in other populations.
And then your boost, do you do it right away? Do you plan it from the start? Or do you wait for it to reduce a bit and do it like, for example, in RTAP7?
No.
The boost at the end?
Here, the boost was delivered to the
based
primary
on the initial
tumor
volume
from
of the tumor.
start, on the initial volume simultaneously. No additional toxicity following this dose escalation, which is also reassuring. Another small perspective is always the discussion about the place of hippocampal saving. Prophylactic cranial irradiation remains standard in limited stages. Can we do better by reducing toxicities? 2 trials evaluated a radiotherapy technique with intensity modulation by sparing the hippocampi, these areas responsible for short and medium-term memory. 2 trials, one Dutch, the other Spanish, which gave contrasting results, not the same neurocognitive test batteries. One of the trials, the Spanish trial, was positive, showing improvement in neurocognitive functions. The Dutch trial did not find a difference. Other larger trials are underway. In any case, this treatment modality can be discussed for some patients. And more importantly, a European trial is currently underway with over 150 patients already included, evaluating the role of prophylactic cranial irradiation in the era of immunotherapy for these patients with localized stages or non-localized. Hippocampal sparing is possible. And so it's ERTC 1901. The latest update, as you know, is consolidation immunotherapy for these patients with localized small cell lung cancer, a bit like the Pacific trial, consolidation with durvalumab, this time for 2 years versus placebo. And the first data, interim results presented at ASCO regarding progression-free survival and overall survival are positive in favor of durvalumab, which becomes the new standard for consolidation in these populations. Half of the patients had PCI, prophylactic cranial irradiation, and these patients did better than those without PCI. So the role of PCI is still relevant and debatable, and patients must therefore be included in the PRIMA lung trial.
Immunotherapy, which again allows for better healing of these stage 3 cases, whether one is in local treatment, which is surgery or radiotherapy. Thank you very much, Antonine. We will stop here for this discussion on stage 3 in bronchial cancers in the framework of the Gustave Roussy chemotherapy courses. You can find all the content online.